Hello and welcome to another edition of Health Matters, brought to you by WCCA TV and the Worcester District Medical Society. I'm your host tonight, Dr. Bruce Karlin, and I am delighted to have with me our two guests, Dr. Terence Flotte, our Dean of the Medical School, and Dr. Dan Lasser, a Professor Emeritus and former chair of the Department of Family and Community Health. I probably botched that, but you'll correct me later. And it's our pleasure tonight to bring you up to date on what the medical school is doing in regards to primary care. So hold on to your seats. How are you two doing?
Just wonderful.
Great.
Thank you.
Great to be here.
It is good to be here. You know, right? We're talking, what is the issue with primary care? Everybody says there's a crisis in primary care. Dr. Flotte, what do you?
Well, maybe I'll just throw it open. So, you know, we were established as a medical school with a special public mission, and a key part of that mission is to train the workforce that's needed to keep the people of Massachusetts healthy, to train physicians and now advanced practice nurses, nurse practitioners for that purpose. So we have to keep pace with what is really needed. And the biggest trend that we're observing in the healthcare workforce needs is the aging of our population. Means that many more people need more care and attention from physicians. And that all starts with primary care. But I mean, Dr. Lasser's been practicing primary care for a number of decades, so he probably could explain primary care better than I could.
Well, the other issue that we're dealing with in medical education is an absolute shortage of physicians down the road, and particularly in primary care. There was a survey that came out that was published just this week from one of the larger recruitment firms, Merritt Hawkins, that said that family doctors for the 15th year in a row were the most highly sought after physicians, and there's a shortage. There's just a shortage of primary care doctors, and one of the difficulties that we face is, for a whole variety of reasons, it is still an issue across the country that it is relatively difficult to convince young medical students to seek careers in primary care, and we could talk about those reasons a little bit.
Why don't we? The two of us have been practicing primary care for decades, as Terry says, but and I can think of no more rewarding career that you could have than practicing primary care. You could the intellectual benefits
Mm-hmm.
and the rewards, the emotional rewards of it. I can't imagine any other profession doing it as well. Of course, we don't get paid as well as any of the other professions or the other subspecialties, and I suspect that has a lot to do with it and the cost of medical education, which again, we at UMass, and I say we because that's where I studied initially. I was in the third class at UMass, but that was part of our mission, and our price structure was much better than any of the other medical schools.
Certainly it is. And it's not just we as UMass, it's we as the Commonwealth of Massachusetts, as the taxpayers, pay in, and there's funds from the state budget that help us particularly to keep medical school affordable. It's not as much from the state as we would like to see, but it still makes a huge difference for many families. But, you know, if I could chime in on this, I think that primary care is a lot more, you know this, but it's a lot more than just not being a specialist. So I think for some of our young people, they say, well, if I want to be a general medicine person, a generalist, and take care of many different conditions, I can be an emergency room physician or a hospitalist, which works only in the hospital and on shifts. And when I'm on, I'm on. When I'm off, I'm off. It's more of a 9 to 5 check-in kind of position. And for them, they see an appeal of the lifestyle. But my goodness, what they're giving up that a primary care physician has is the opportunity to have that continuity with patients and families over years, over lifetimes, over generations.
So one of the things that I pull from this is that some of the decisions are made for economic reasons. It's so that what UMass has done in the past has been, fabulous. That you can leave your or head out into your career without ridiculous debt. But most of the students leaving any medical college have huge debt and need to have this burden hanging over them.
Well, in addition to being roughly half the tuition cost for an in-state student, if they pledge to practice primary care and then actually do the service obligation of practicing primary care in Massachusetts for 4 years afterward, then a significant amount of the tuition is forgiven. Otherwise, if they take, it's called the learning contract. So it ends up being has roughly a value of about a discount of about $22,000 off the total.
That's huge for somebody starting their career. So what are the other problems that you see that lead to?
Well, I think the primary issue is the financial issue. I met with a rising second-year medical student today at noon who comes from a family that doesn't have means, and he was talking about wanting to go into primary care, and at the same time he said, I know that by the time I graduate and finish my residency program, I'm going to have a debt of some sort, and in addition to that, I'm going to either be starting a family or I'm going to want to buy a house, and student debt, not just at UMass, it's worse at the private schools, is certainly a factor to take into account, and part of it relates to the way the primary care physicians are paid right now. In Canada, about a decade ago, they made a conscious decision to change the ratio between what they were paying their specialists and what they were paying their primary care doctors. They still paid their specialists more money, but they lowered the gap just a little bit. And within a few years, they found that they had a larger percentage of graduates going into primary care. And there's no study to show this, but I suspect it's a matter of respect or how society appears to value the work that you do. And I'm not going to begrudge anybody for how much money they make, but it's the relative value.
I get the sense, though, that more people would do primary care if they could afford to, and that it's not the respect or anything like that. Yeah. It's a matter of these pressures. So what are we doing? What else are we doing to promote more primary care, or do we need to? Is there some other way to deal with this?
It's not all doom and gloom. I think, at least for what we've done at UMass, it has been to continue to emphasize the role of primary care in our faculty practice plan. There's a very robust group of primary care physicians in general medicine and pediatrics and family medicine, and they have the school has always been ranked high in national surveys for its training and its output of primary care doctors. So I think that the medical school's got something that it can really be proud of, and it's some things like getting first-year students out into the community and developing an appreciation for what it's like to be in the community, and it is having leadership within the school, including the former Senior Associate Dean for Education, who was a graduate of our program, and so having primary care physicians who are in leadership positions and who have key roles within the curriculum. And I have to say that the school, the UMass Medical School, has been a very strong supporter for the notion that we want a significant percentage of our graduates to go into primary care, and it has showed.
So I think one other thing, just to speak in terms of our prospective sort of strategic planning, we saw the need to train more physicians, both primary care and specialists, because there's also a projected deficit of specialists. The AAMC, which is the Association of American Medical Colleges, all accredited medical schools, are in this. They have a very specialized Center for Workforce Studies, which is got economists and such to do these projections. They project a total supply deficit of physicians of up to 121,000 by 2032, which is not that long from now. It's roughly a decade away, including roughly an equal number of primary care and specialty physicians. But getting to the primary care issue, we thought, looking at the total deficit and the primary care deficit, that we needed to expand the medical school, train more physicians, and to do that we had to establish some strategic partnerships, some new locations to train our medical students in the hospital. And one of those is at the Bay State Health System in Springfield, which is a major academic health system with many different residencies and academically oriented programs, not as academically oriented as Worcester, but some great teachers and physicians. And so we set them up as a regional campus and created a track which is really oriented toward primary care, where the students get their basic studies, gross anatomy and the like, in Worcester, but then for the second half of medical school, get all of their clinical experience in practices that are out in Springfield and all across Western Massachusetts, specifically both to increase the capacity, the training capacity, how many docs we're going to turn out every year, but also to get the students thinking about careers in primary care and the broader concept of population health.
Well, I'll speak as a member of the third class and tell you that I compared notes with friends at other medical schools at the time, and we were way ahead of everybody in getting people out into the community and getting a context for your learning. Mm-hmm. So you say, well, they're not as academically oriented, but it was the nidus, it was the focus of your learning to say, well, I saw this out in the community, or and now when you go back and you do your studies, it made it so much more vibrant. And when I compared my notes with friends at Case Western, friends at Dartmouth, and other medical schools, that they were envious of what we were doing. That was way back with Hugh Fulmer as the founder of your department, mm-hmm. Dan, and they had just such innovative approaches to it, and I think you're continuing with it. I think your project out in the Berkshires is really exciting.
Mm-hmm. And there's also no question that if you train people in areas that need doctors, they are more likely to stay there and to practice.
So that's that 4-year contract sort of thing.
Well, in addition to that, we're working with Bay State on developing a new family medicine department and a new residency program that'll be based in family medicine in the Berkshires, in the Pioneer Valley, and there's no question. Well, the data show that if you train people in those settings, some of them will stick and they'll stay there and they'll join the faculty. And
they learn the excitement and the joy of primary care, which maybe we're not relaying it as much as we should. But I as I said before, I can't think of a better career. And I tell I'm working now in the ambulatory clinic at St. Vincent's, and it's you try to get some of that excitement because you get a lot of the more specialized training as their everyday stuff, but you get out into the clinic and you say, oh, isn't this fun?
Well, I think we do try to also select students at UMass. We recognize that we have a special mission, and we try to select students who we don't guarantee that that go into primary care, but who are oriented toward this concept of trying to relate to people and have long-term relationships with people who might be their patients. Who would be likely to gain that satisfaction from seeing patients progressing, living with them through illness and wellness and life's changes.
Just being there as the pilot through the harbor.
Yeah, exactly.
So there's one other feature that is taking greater prominence at UMass. And I know sometimes in thinking about the primary care workforce, people get concerned about what about nurse practitioners or other people who are getting into primary care. And I can say, as someone who's always worked with nurse practitioners through my whole career, there's plenty of work for people to do. And UMass has put a particular focus on interprofessional education and people working in teams and part of
Teams to get
and part of the medical school is the graduate school of nursing and so the medical school placing a greater focus on interprofessional education is really providing a pathway for teams that will get out into the community.
I will say, even this type of concept, whenever there's a management of a patient who has a chronic condition, can be particularly helpful. So I've worked with nurse practitioners myself in a subspecialty practice. Every care center that takes care of children and adults now with cystic fibrosis has integrated nurses, social work, nutrition, and other types of services.
So a sort of primary care focus is now seeping out into the subspecialties now that you're having greater success in prolonging the lives of those that you're caring for.
Exactly. I mean, with the whole issue of team-based care, where instead of being centered on the doctor, it's centered on the patient, and everybody has their role to play in helping the patient. But I think the care of chronic illness is really where this comes together in a way that is absolutely required. And to be honest, sometimes the nurse practitioner either has more time to spend with the patient and family, or might actually, in fact, have had more of their training oriented toward issues like family dynamics and the like. As you know, I'm somebody who's worked in genetics a lot in my career, my research, but I think it's pretty well shown now that in most cases with diseases, only about a third of it is due to genetics, probably about a third of it is due to individual behavior, and the other third is due to other kind of social determinants of health, the community somebody lives in, and other kinds of things in their environment. Those numbers may not be exact, but it is actually.
We'll hold you to them.
It is actually it is less than half of it that's genetic, and there's a big chunk of it that is to the personal behavior and lifestyle choices, and a big part of it that's other environmental. And those other areas are often certainly that is part of what community health is about. Primary care docs are more oriented toward those factors than specialists are, and sometimes nurse practitioners have even more time to dig deep into some of those non-medical, non-surgical things you're not going to do a surgery
that
for.
You don't associate with medicine, but are
they're part of health. They're part of disease, part of health,
important.
part of wellness, and really can make the difference in somebody's length and quality of life.
So you were sharing with me some statistics earlier about the aging of the medical community.
It's a very interesting aspect of the workforce issue that we've talked a lot about at the national meetings. But as of now, licensed physicians in the United States, almost a third of them, 31%, are age 60 or above. Now, we don't know exactly what that's going to mean for the workforce. Does that mean that people who are practicing physicians going to practice much longer? We think there's somewhat of a trend toward that, but it also means we're going to have many more physicians leaving the workforce in coming years. And the generation coming up behind, if you know, the biggest cohort of physicians is in the baby boomer cohort, but as we age along with our
Cohort.
our cohort, there are fewer people in the next generation to take care of us. We often think about that in terms of family caregivers, but it's actually true of providers as well. And I hadn't. It's really only been for these workforce projections that there's been a lot of emphasis on trying to understand what the life cycle, if you will, of the physician is going to be.
Well, my wife was a rheumatologist, and she retired a couple of years ago. But she told me that I can't. so I'm going to be on that part that I'm going to be 92.
Well, we need you.
Yeah, right. So, well, let's talk about those issues. So, I've moved part of my practice over to the ambulatory care clinic because I really can't find the primary care physicians to do it the way Dan and I have liked to do it.
Yeah.
And I find that it's excellent care that they're getting at the ambulatory care clinic, but my patients keep asking me, well, you're semi-retired, when are you going all the way? And I say, well, I don't want to do it until I'm not doing it well. I don't want to stop until I'm not doing it well. But there are others that are burning out. So how do we, what is UMass doing about, making sure that I'm staying up to snuff and that I'm not burning out?
Well, I think there's a lot packed into those questions, but I think certainly the aspect of this that relates to self-care, to make yourself perform better, to be happier and be more well. That's something we have recognized that we need to train medical students in how to do with intention, to do very intentionally.
So in other words, you don't just go home and read your journals, but
take time for exercise, sleep, some other form of relaxation, because you're going to need to be in it for the long haul. But the burnout phenomenon is actually very acute in medicine. Dan, I don't know if you want to talk a little bit about it from the standpoint of you've been leading a department of physicians for many years and are seeing this coming up now with increased frequency.
Well, the measures for burnout, there are some standardized scales that we use, and the measures are scary in terms of the level of burnout across the entire medical staff, not just in primary care. And there's no question that the workload has become more difficult, and people talk about the amount of work that's done on the computer. You go home and you have dinner, and then you spend a couple hours on the computer after dinner trying to catch up with your notes.
It's fair to say that the computer never met its promise. It was supposed to cut our workload, and in fact has probably increased it dramatically.
Yeah, I think so. But also the expectations of insurance companies and expectations of physicians, and increased emphasis on productivity. Patients don't like it, and the physicians don't like it, having to see a patient every X number of minutes, and so on, and so.
That's not real measures of productivity. That's a real warping of Taylor's original study, time motion studies, which were basically to say, how do you optimize the patient, the worker's time. It was not to say, hey, we've got, you're supposed to see patients every 15 minutes. We've really warped the original studies, but.
So there's a few things that we're doing within the hospital system right now. There are some pilot studies that are underway to try and increase the number of staff who are in the clinics when the patients are being seen, or we're making increasing use of scribes. I went to my faculty and I said, would you be willing to see one additional patient in the afternoon if I told you didn't have to touch the keyboard for the entire afternoon and you could just look face to face with your patients every time you see them?
And if they actually did it that way, they could probably see 5 extra patients.
And the response was was practically unanimous, and we studied it, and it was successful. So there are things that it's hard to re-engineer medical practices, but we're working on trying to
So,
transform.
Dr.
some-
Flotte, what do you?
Well, I was just going to say, I'm going to hit on this point, how it ties into burnout, because it's not just, I mean, we all signed up to work hard. I
Yeah.
don't think that's what it is. I think, well, not exclusively. I think that the thing that we're seeing with the electronic health record is that the proportion, you just hit on it, the proportion of time that somebody's work is spent with the patient and the family is sort of inverted. I think for most studies, it's like 50 to 55% of the time is spent feeding data into the electronic health record. That's not a positive, but we're still, I think, learning. I'm not we as individuals, but we as systems are learning how to use that better. I do think we've decreased errors due to pharmacy and medication. There are a few things like that, but there's been a lot of negative along with it as well. The Scribe project is very exciting, and we're going to try to figure out if there's a way we can get students who are trying to get into medical school. When they're in medical school, they're a little too busy to do that, but students who are trying to get into medical school to get
Learn to be a scribe.
Learn to be a scribe and get a little bit of exposure that way. We're innovating. You know, we are an innovative school, and so we're trying different angles to try to get at.
I think the challenge is that and we all experience this. Nobody's afraid to work hard, and so long as the work is meaningful. And going back to our original training, I'll bet you guys were all this way. Also, you know, I loved working hard, and I didn't mind the long hours, but it was meaningful work. And so the challenge is to keep the work as meaningful as
And
possible.
to cut, well, believe it or not, we've talked for quite a bit. It's been my pleasure to have as my guests Dr. Terence Flotte and Dr. Dan Lasser from UMass Medical, the Dean and former Chair of...
Family medicine and community health.
There you go. This is Dr. Bruce Karlin, hoping you keep watching Health Matters, brought to you from WCCA TV and Worcester District Medical Society. I can't speak, but anyhow, thank you for watching.
Thank you.
Thank you.
Quickly.